So this chapter is going to cover a little bit of an overview of genetics and conception, as well as fetal development and topics along that route. So when we're talking about genetics and genomics, genetics is like the scientific study of our genes. Genomics is how it's applied to what we do. So as nurses, we use genetics, maybe not on the scientific level, but we use it to provide education to our patients. We use it to determine who needs testing, and we use it to help our patients understand their risks of acquiring certain genetic conditions and things like that. It helps guide us to determine those prenatal tests, like you see at the bottom, the maternal serum alpha fetoprotein we're going to talk about, doing amniocentesis, which gives us those genetic markers as well. The reason in women's health that genetics and genomics is so important is because one of the biggest reasons for pregnancy loss is a genetic defect that is not compatible with life. So you'll see where people have multiple miscarriages and it's unknown why those are happening. That's usually the first thing you're going to look at is genetic testing to determine if there is some kind of genetic defect being passed on from either parent that is contributing to this incompatibility. Another common reason is gynecological disorders as well. So prenatal counseling, screenings, determining who is at risk is a big part of what you would do in nursing related to genetics specifically. So when we're talking about clinical genetics, it's not so much that you need to know how the specific scientifics of it, but you should understand what it means to have autosomal recessive versus dominant, as well as sex-linked autosomal versus, sex-linked um, dominant versus recessive, as far as how you teach your patients their risk. For instance, if you have somebody with an autosomal recessive disorder like sickle cell disease, you have to get that from both parents in order to have the defect or the disease. So in this case, you only have a 25% chance of actually having a child with that disorder because of you having to get it from both parents and you only pass down one gene. So there's a 50% chance from each parent they're going to pass on that defective gene, and then in order to have both of them, that's a 25% chance. When you're talking about those sex related X-linked disorders, when you have an X-linked recessive, because there are two X's on a female, if it's recessive, you can't get both of those. So in this case, women are carriers for this, but men are the ones that are going to display those traits. This is Duchenne's muscular dystrophy, we'll talk about when we get to pediatrics. That is a X-linked recessive, so it's almost exclusively found in males. You would have to get that disorder from both the mom and the dad in order for a female to actually display those characteristics. And a lot of those X-linked recessive disorders are not associated with people who reproduce always. I don't want to say ever. But so it's much less of a chance you're going to have a female. It's not completely 100%. So on page 131 in your textbook, it does show screening questions for genetic disorders. Some of the things that we'll talk about with pregnancy: age of the mom. When you hit 35 years old, you are considered a geriatric pregnancy. Seems pretty young, right? But the reason they set 35 is because that's when you have a much increased risk of genetic defects. So usually if mothers are 35 or older, they're going to do more extensive genetic testing than they would on a younger mother. For instance, looking at family history, looking at lifestyle choices, all those things they'll take into account if they determine how likely it is that they need that genetic testing. So I'm not really going to go into detail about things like conception and development because you've learned about this in your science courses. Hopefully by now you know how conception and fertilization and all those things happen together to create a fertilized egg that it implants into the uterus and hopefully blooms into an embryo and finally a fetus. What we need to know as a nurse is the functions of the amniotic fluid. What is amniotic fluid? It's the fluid that is inside the amniotic sac. Inside the sac that holds the baby, there is fluid surrounding that baby. And some of the functions of that amniotic fluid is providing cushioning. It provides temperature control for the baby to keep an even temperature in the environment. It provides lubrication for the baby, meaning that their skin is very friable. It is easy to actually peel. If you take care of a very early premature infant, you can actually peel their skin off when you touch them because their skin is so thin. So when they're in utero, it's the same way. So that fluid keeps them from sticking to the amniotic sac and peeling their skin off. It allows for even growth. If you don't have enough fluid and baby is up against the amniotic sac, then they're going to have one side that grows that's towards the middle of the sac and one that's up against the sac. The side is not going to grow as well. So even growth, it allows cord support, that umbilical cord, if it's able to float freely in the fluid, it's going to keep much less likely to keep from getting kinked, as well as even getting wrapped around baby's neck. It also provides infection control measures to keep baby healthy. When we're talking about the umbilical cord, one of the things that's important when babies are born is you're going to look at that umbilical cord and count the vessels. There are several disorders that are associated with genetic disorders that are associated with an abnormal number of veins or arteries in that umbilical cord. There should be 2 arteries and 1 vein. There's a couple ways to remember this. One is that you only have 1 valedictorian, so there's only 1 V, only 1 vein. Another way is AVA, so AVA, artery, vein, artery. And those are important to note if there is any kind of alteration. So here are just some pictures that show you. The top and the right pictures are found on page 135 in your textbook. If you want to get a clear view, this just shows you the process of fertilization and then implantation. Generally, fertilization most commonly happens in the fallopian tube, like we talked about. Most instances of ectopic pregnancy occur in the fallopian tube because that's a lot of times where that fertilization happens. And then that fertilized egg travels down the fallopian tube over several days and hopefully implants in the uterus, because the uterus is the only place that can allow for growth of that fertilized egg into a fetus. So when we're talking about the placenta, so we as nurses need to understand how the placenta works, what it does, and why it's important. There's lots of hormones produced by the placenta. The placenta is like the connecting organ between mom and baby. So it allows for exchange of nutrients, exchange of gases. It also produces hormones that are essential to maintaining a pregnancy. There are 4 hormones that this placenta produces that are important. One of those hormones is estrogen. So estrogen is important because it allows for uterine growth. So it increases metabolism, and it also increases vascularization. It increases blood flow to your body to allow growth of that uterus, to allow for this expanding baby. Some of the side effects you can get because of that, because of all the vascularization, and we'll talk about the pregnancy adaptations in the next chapter. And related to that estrogen, so something they get is called Chadwick's sign, where they have a bluish discoloration to their vagina and their cervix, and that is because of that increased blood flow. They'll also easily get nasal stuffiness and nosebleeds and things like that because of that increased vascularization pulling fluid into those sinuses. So common symptoms, those are related to that estrogen. So the estrogen allows for growth of the uterus. Now, progesterone is called the hormone of pregnancy. Keep that in mind, that it is known as the hormone of pregnancy. And what this does is it maintains that endometrial lining, the lining of the uterus, and it also decreases contractions. Let me give you an example. When I was pregnant with my second child, my first child was premature. And it was unknown why. So with my second child, I got progesterone injections from week 15 of pregnancy up till week 36. And the reason they did this was to decrease those contractions that may have contributed to preterm labor. So that progesterone calms it down, because think of a embryo as a foreign body. All your body sees is something, some kind of parasite is trying to attach itself to your uterus, and your body is very good about trying to get rid of things that it doesn't think are supposed to be there. So your uterus is going to try to contract to get rid of that. Progesterone kicks in to stop those contractions, so it doesn't get rid of that fetus that we want to grow. These two, estrogen and progesterone, are increased by human chorionic gonadotropin, or HCG. Most people have at least heard of HCG because that is the hormone that pregnancy tests are based off of. This is the first hormone that the placenta starts to produce, and what this hormone does is increase production of estrogen and progesterone. So y'all know how the endocrine system works, as far as oftentimes it's a cascade of how these hormones work together. With your thyroid, it's not just the thyroid. The thyroid has to be stimulated by the pituitary, and so on and so forth. Same thing with the placenta. So even though estrogen and progesterone are the two big hormones that help maintain that pregnancy, those are stimulated to be created by that HCG, and that's where we measure that test. So it promotes the continued production of those hormones, so will continue to maintain that pregnancy. And that's also why HCG levels are higher in the first semester and then progressively decrease after, not semester, trimester, and then progressively decrease afterwards, because it is not as necessary, because at that point your body gets better about maintaining that pregnancy on its own. The last hormone that's not really as big of a focus as the first three is called the human placental lactogen, or HPL, or the human chorionic somatotropin, HCS. Both of these are related to maternal metabolism as well, but they also help stimulate breast development and milk production. On page 164 in your textbook, there's a really good chart that lists lots of hormones, not just these, but it talks about insulin, it talks about thyroid hormone, talks about lots of hormones in your body and how they're affected, as well as their functions and what they do. So that's a really good chart to use as a reference. So when we're talking about fetal maturity, so ideally, a fetus grows over 40 weeks or so, calculated from the time that conception happens. So usually about 2 weeks after a woman's last period is how that would fall into play. So fetal maturity, different parts mature at different times. Everything is in place though by week 12. That is why a large majority of miscarriages occur in that first trimester. A lot of people have this fear of telling people that they are pregnant until after that first trimester because of that increased risk of miscarriage. And that's because all those things are developing. So if you have, for instance, a genetic disorder that would result in incompatibility with life, as that whatever system it is that is affected by that genetic disorder starts to develop, that's when the body would recognize this fetus is not going to be able to live on its own. So it aborts that fetus because it wouldn't be viable outside. When we're talking about viability, this is the capability of the fetus to survive outside the uterus. At this point in the world, they are able to save newborns and premature babies as early as 13 weeks, good Lord, 22 weeks of gestation. If it's prior to 22 weeks, they are not going to perform those life-saving measures because they have, at this point in time, not been able to make that successful. I cared for a woman one time that spontaneously ruptured her membranes, meaning her water broke at 21 weeks. And it was heartbreaking because she tried to hold that baby in for 5 days so she could make it to 22 weeks. So baby could even have a shot at surviving outside of the womb. And at 5 days, one morning she woke up and the baby had birthed itself, and of course had become stillborn. So before that 22 weeks that babies cannot be viable outside on their own. Now you see research changing all the time. You're seeing where they're creating artificial wombs like robots that babies can grow in. So this is probably going to change in our lifetime of the advances we're going to see of potentially saving babies early and earlier. When we get to the high risk newborn chapter in a few weeks, I'll talk about those ethical implications of how early is too early when you're talking about viability. So as far as the different body systems, on page 143 to 146 in your textbook, it is a really, really good chart that details fetal development. It shows the development of the general systems. I would recommend you have an idea of kind of when certain systems develop, not necessarily that you need to know specifics. Like for instance, when we're talking about spina bifida and your folic acid intake. Ideally, folic acid should actually be started before conception even occurs, because the spinal column where spina bifida occurs actually finishes closing by 4 to 6 weeks of gestation, sometimes before people even know that they're pregnant and the damage is already done. So you'll see a lot of those early primitive things that are formed sometimes before people even know that they're pregnant. So when we're talking about the different body systems, fetal circulation, the normal fetal heart rate is 110 to 160 beats per minute. Same thing for newborns. You will see it progressively decrease over time throughout the pregnancy. For instance, when they're early in the pregnancy, 8 weeks, 12 weeks, when you can first start hearing it by Doppler, they may be close to that 160 beats, maybe even a little over the 160 beats. And then it will progressively go down. Maybe by 36 weeks, the baby's heart rate is only 125. That's okay. You expect that because as their heart gets bigger, it has to beat less times to accommodate the amount of cardiac output it needs. Sudden drops in heart rate are not okay, but progressive drops over time are okay. When we're talking about the respiratory system, babies starting at about 37 weeks start producing this what is like a detergent called surfactant. And when we get to newborns, we'll talk about surfactant in much more detail. And that's why there's a big difference in a 36-week premature infant to a 37-week full-term infant. This is one of those primary reasons, is because of that surfactant. Before that 37 weeks, if they haven't started producing this yet, they're at much greater risk of respiratory distress and things like that. So that is why that surfactant is so concerning, and why it's preterm labor is, or preterm birth is more concerning than full term, or one of the reasons. So when we're talking about multi-fetal, again, we're not going to go into the scientific details. You have your scientific classes like for that. But when we're talking about multiple fetuses, they can be identical, where they came from the same egg and same sperm that just got a little crazy when it started splitting and split off into two entire human beings instead of just splitting into individual cells. Or you can have dizygotic, which is your twins that are came from two different eggs. Mama's ovary got a little too excited, released two eggs, and got fertilized by two separate sperms. So your monozygotic are identical in genetic makeup, versus your dizygotic. They are no more similar than any two siblings that have been born at different times. So you see twins that look drastically different from each other, and that's because they are no more alike than any other sibling set, even if they had been born separate. So when we're talking about factors that can influence development of the fetus, I mentioned folic acid already and how that affects it, but there are also a big thing with teratogens. A teratogen is something that is harmful to a fetus. It will either cause permanent harm or miscarriage. So this chart you see on the screen, I know on your PowerPoint is probably hard to read. It is on page 148, so you can see it a little bit better. And you can see how when you are when a certain teratogen exposure occurs, it relates to as those different body systems develop. So in the first few weeks, if they're exposed to some of these, they're more likely to have neurological and neural tube defects or spina bifida, because that is when that neural system is forming. And that is why it's so important to understand fetal development and when it occurs, is because it helps us determine when exposure occurs, what may be the potential outcomes. And that sensitivity is going to change a little bit based on timing as well. So not only drugs, um, alcohol, cocaine, tobacco, even legal drugs. There's been this big thing on the internet, not on the internet, I'm sorry, in the news lately about Zofran or ondansetron. If you took ondansetron while you were pregnant, contact us. Lots of drugs have the potential to be a teratogen, and they're usually categorized as A, B, C, D, or X, meaning you definitely should not take those, period, end of story. There's no reason to take those while you're pregnant. And then A through D is various risks. D is you should only take it if the risk outweighs, or the benefit outweighs the risk. Up to A, there's no problem. The problem with a lot of drugs is it is unethical to do drug testing on pregnant women just to find out the outcome. Most of the studies we have on medications and various different things and how they affect pregnancies is just based on this woman took this and this was the outcome. You can't actually make a study about it ethically. We'll talk about this with children as well. There's not as many studies with children. So that's why a lot of drugs, it's not necessarily harmful to give a child this drug. It's because it hasn't been studied and they cannot successfully say, yes, you can give this drug. So unfortunately, a lot of drugs are just categorized as do not give this, not because they know it's harmful, but because they don't know, and it's better to err on the side of caution. So some other things, various different chemicals, infections. So we will talk about torch infections in more detail with our high risk. So torch are infections that are more specifically cause long-term complications for a fetus. So this is your toxoplasmosis, which is the reason pregnant women are not supposed to change litter boxes, is because of that toxoplasmosis. Things like rubella, if they haven't been immunized and they're not immune to rubella and they contract it, that can cause severe neurological deficits. Herpes, if they pass through the birth canal, a mom has an active herpes infection, that is contraindicated. Things like that we'll talk about in more detail. Maternal conditions, such as if mom has diabetes, if she's had gastric bypass, her nutritional needs are going to differ. If she just has malnutrition in general, somebody who, say, is lower income, that can affect their ability to get the nutrition they need to support that fetus. If they have PKU, or that phenylketonuria, that can also affect it as well. So there are lots of things that can affect that fetal development. And knowing when exposure occurred can help us determine what to look for and what genetic testing to do for that.